Chronic venous insufficiency syndrome, relatively common, especially in westernised countries, associated with venous hypertension. But in this clip we want to look at the clinical features of the condition. What do the patients suffer from and how do we recognise it? Now the first thing I want to talk about is ankle brachial pressure index. Now the ankle brachial pressure index is the ratio between the blood pressure in the brachial artery and in the posterior tibial artery in the ankle. Now, if someone's got peripheral arterial vascular disease, the blood pressure in the brachial artery is going to be higher than the blood pressure in the ankle. And that points out to peripheral arterial insufficiency, peripheral arterial disease. But we're not talking about arterial disease, we're talking about venous disease. So it's important to differentiate because it's got significant implications for the treatments. So in a normal situation, the blood pressure is going to be pretty well the same in the brachial artery and in the posterior tibial artery in the ankle. So the ratio we would expect in a normal person, theoretically, to be about 1:1. That would be normal. And what we say is there's peripheral vascular disease present if it's less than 0.8. In other words, if the blood pressure is 20% lower, the systolic blood pressure is 20% lower in the ankle compared to the arm. So in chronic venous insufficiency syndrome, the ankle brachial pressure index is going to be normal. So that's going to be normal. Now, another feature that we can get is varicosities. Varicosity, varicose veins. And we can also get another feature called an ankle flare. Now varicosities are the tortuous dilated superficial veins, the varicose veins that we see in the leg. You can actually get varicose veins in other parts of the body, in the esophagus for example, esophageal varices. But here we're talking about the legs. So you can get varicosity as a result of the chronic venous hypertension. The varicosity normally caused by failure of the valves in the perforator veins, allowing reflux of blood from the high pressure deep venous system into the superficial low pressure system. And the ankle flare is caused by dilated small vessels such as venules, dilated venules around the ankle. And what you tend to notice is when the leg goes down into a dependent position, the gravity fills up these small vessels and we get this discoloration in the ankle. So this is a differential diagnosis, this one. Just trying to classify these a bit because it gets a bit confusing having just lists of clinical features. These ones are caused by the reflux of blood, the ankle flare and the varicosity, so they kind of go together. Now, the increased hydrostatic pressure in the capillaries means that the tissue fluid is not effectively reabsorbed at the venous end of the capillary as normal. This means there's accumulation of fluid in the tissue spaces. In the UK we call that edema. In the States you leave off the O, it's edema, it's the same really. So we can get this edematous swelling, very characteristic of peripheral venous disease. So we get swelling. Now of course edema can be caused by localized venous disease, but it's important to remember that edema can also be caused by systemic disease. So edema can be caused by congestive heart failure, or it can be caused by renal failure. So it's important to differentiate whether the cause of the edema is localized or systemic, because the treatments are going to be different. And one way to start thinking about this is, if it's a systemic cause of the edema, it's likely to be bilateral. The edema is likely to be the same in both legs. Whereas with chronic venous insufficiency, while it can affect both legs, typically one is worse than the other. And this gives rise to the leg feeling very tight. The skin feels tight and the patients complain that it feels tight. Now, the edema is caused by the increased movement of water from the intravascular compartment into the interstitial compartment. And I'm just going to write another word down here. Hemosiderosis. 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 Now, hemosiderosis is the brown staining that is characteristic of chronic venous insufficiency syndrome. What actually happens is you're aware of the fact that there's these capillaries with the vascular endothelial cells. But because there's chronic venous hypertension, the size of the gap is increased because the capillaries are being opened up by the increased internal hydrostatic pressure inside. Normally, of course, the red blood cells don't fit out of the small vessels, but because there's increased size of the gaps in between the vascular endothelial cells, the red cells can escape into the tissue spaces. So we get extravasation and we get red cells in the tissue spaces. Now, these are phagocytosed, so the cells themselves are removed, but the pigments are left. The hemoglobin pigment is left, and that gives rise to the brown staining. And the brown staining is caused by the presence of hemosiderin, and hemosiderin is the brown breakdown product of the hemoglobin, causing the hemosiderosis. So I think it's fair to say in all cases of chronic venous insufficiency syndrome, there's going to be some brown staining. It's a very diagnostic feature. And when you see the brown staining, the hemosiderin causing the hemosiderosis, then that is pretty well diagnostic of venous insufficiency. And I'm going to kind of group these together because they're related to the increased permeability of the capillaries. I know when you're trying to learn clinical features, learning lists is just bemusing, but if you can sort of work out what's causing it, it starts to make a bit of sense. Now, another thing that these patients complain of is cramps. Cramps. Now, part of this is that because the blood is not able to flow freely through the small blood vessels, then less fresh blood is able to get in. Because the blood that's here can't get out at the venous end of the capillary, it's harder for the blood to get in at the arterial end of the capillary. So there's less flow through of blood. That means the amount of oxygen delivered to the tissue cells, so the tissue cells will be in this space here, they're getting less oxygen, they're going to be hypoxic, and that can give rise to the accumulation of lactic acid. And the swelling is going to press on the small vessels as well. So because there's a lot of fluid accumulating in this intravascular space, it's not unreasonable to assume that if there's some small blood vessels like an arteriole that's feeding a capillary bed here, there can be pressure on the small blood vessels, reducing the blood supply to the capillaries, therefore reducing the oxygen supply to the cells. So these cramps give rise to throbbing, aching. It just feels unpleasant. The leg feels unpleasant. And as well as that, you're going to get leg fatigue. The patients complain that their legs feel tired. And the reduced blood supply means that the skin is less viable. So we get skin atrophy. Atrophy just means a deterioration of. So the quality of the skin is reduced. There's atrophy of the skin. And over time, this can result in lipodermosclerosis. Now, some people call it lipodermatosclerosis. So lipo is the fats, the dermo is the dermis, sclerosis means hardening. So over time, the reduced blood supply and just the reduced viability of the whole thing mean that the adipocytes in the subcutaneous tissue are going to die off. And they're replaced by scar tissue, hard scar tissue. And characteristically what this causes is the champagne sort of shaped leg. So you get the legs kind of swollen here in the calf, but then it goes down to a very thin ankle in the gaiter area, like an upside down champagne bottle. So we have edema here causing the swelling on top. But then because the subcutaneous tissue has been replaced here by fibrous tissue, this is very hard here. And it feels hard when you touch it, because the fat has been replaced by scar tissue. So fat, skin, hardening, but actually the fat is replaced by fibrous tissue. So I'm going to group those two together because they're all this group together because this is kind of related to poor blood supply. The lipodermosclerosis, the cramps, the leg fatigue, the skin atrophy. Now, another feature that patients complain of is eczema. And eczema actually is just another word for dermatitis. Dermatitis is actually probably a much better term because it's inflammation of, itis, inflammation of the dermis. Eczema is a bit of an old-fashioned term, really. But this is associated with itching. These legs are often very itchy. And also something else called restless legs. Now, my thinking here is that these are probably caused by the accumulation of toxins and things in the leg. The accumulation of toxins will stimulate the receptors, the peripheral sensory receptors in the dermis. And actually, we know now that in the dermis there are specific receptors for itching. So these can be irritated. And again, the accumulation of toxins and things can cause restless leg syndrome. I don't know if you ever had this. I get it when I'm working nights. You just don't know where to put your legs. It's a horrible feeling in your legs. And you need to move them all the time. So you end up having restless legs. You have to keep moving around to try and reduce this unpleasant feeling in the legs. It's not a pain, but it's a very unpleasant feeling. Renal patients often complain of it as well. So we'll group those few things together as not very scientifically, but we'll say that they're the accumulation of toxins. Now, the pain from legs with chronic venous insufficiency and the unpleasant feelings are variable. So what makes it worse and what makes it better? What modifies the features? This is always remarkably useful when you're trying to assess a patient and diagnose a condition. I will always ask patients, what makes it worse, what makes it better? Because that tells you quite a lot about the nature of the pathology. So it's worse when it's warm, better when it's cold. So what's happening here is in the warm, there's going to be peripheral arterial vasodilation. More blood is going to go into the limb, into the subcutaneous tissues, because there's going to be vasodilation in response to warmth. And that's going to increase the total amount of blood in the leg. So when it's warm, if we think about the leg here, there's going to be vasodilation of the vessels going into the leg. So there's going to be more blood. Now that's okay in you, because when you peripherally vasodilate, when you get arterial peripheral vasodilation in response to increased environmental temperature, then your veins will simply drain it away. But these people are unable to do that because they've got ongoing venous insufficiency. And conversely, when it's cold, there's going to be peripheral arterial vasoconstriction. Less blood is going to go into the leg, and that will reduce the level of congestion. Now, these people also get more pain. It's worse when the leg is lowered in the down position. Because again, if the leg is down the way, then gravity will allow more blood to flow down into the leg, increasing the level of congestion, increasing the clinical features. And conversely, when the leg is raised up the way, blood is able to drain out because it's gravity assisted. And that makes it feel a bit better for them, which is good. And also it's worse with exercise. Exercise makes it worse and rest tends to make it better. Particularly after exercise, these patients can have pain and significant discomfort. So again, when we're exercising, that's going to increase the oxygen demand of the musculature in the leg. There'll be an increased blood supply because as the levels of oxygen in the tissues drop, there's going to be a reflex of vasodilation, increasing the blood supply. So more blood is going to go into the limb. But again, we can't drain it out. So the exercise is going to increase the severity of the clinical features. Whereas at rest, there's reduced blood supply going in. The congestion is not as severe. So worse when it's warm, worse when the leg is lowered, worse after exercise, better when it's cold, better when the leg is raised up to assist the gravity drainage of blood, reducing the congestion, and better at rest. So we can group those together as the better or worse clinical features. Now, venous insufficiency, as well as being unpleasant, is actually a life-threatening condition, or it can be. Because there can be complications. Infection. These patients are much more prone to infection. Cellulitis can be a life-threatening condition. In your patients with chronic venous insufficiency, always maintain a high index of suspicion for the development of infection, because it can be life-threatening. Pain, I think, will include that as a complication. And the other one that we see very commonly and spend a lot of time treating, venous ulceration. So these are all potential complications. And of course, once the ulcers form, they can be difficult to treat and get rid of. So that's another group of clinical features there, the complications. So it's chronic venous insufficiency syndrome. A syndrome is a group of clinical features. So we see here that there's groups of clinical features that will aid us towards the diagnosis of chronic venous insufficiency syndrome, that the patients will report to us and we will observe. We will observe for the clinical signs. The patients will report the symptoms. We'll use this to make an assessment, but we remember it's a syndrome. There are a variety of clinical features that can present as a result of the chronic venous insufficiency syndrome and the chronic venous hypertension, all caused by failure of the valves of the veins that mean the blood does not flow freely from the periphery back to the centre. This is a disease of the veins, meaning that venous return is insufficient.